Hello, I am Dr. Rittoo. Now, today we are going to talk about the different behavior of cardiac troponin T and cardiac troponin I. It has been conventional wisdom for many years that cardiac troponin T and cardiac troponin I are equivalent biomarkers for the diagnosis of myocardial infarction. They have been held as cardiac specific. It was thought that, only the myocardium contained cardiac troponin T and cardiac troponin I, and therefore the presence of these biomarkers in the circulation represented myocardial damage. This view was challenged in 2004 by the paper that you see in front of you, published in JACC. It showed that a wide spectrum of patients with neuromuscular diseases have a persistent elevation of cardiac troponin T, but not cardiac troponin I. It was argued from biological evidence from previous studies that cardiac troponin T is a marker of skeletal muscle regeneration. Chronic skeletal muscle diseases release cardiac troponin T through this process of regeneration. Since 2014, a number of studies have been performed confirming that cardiac troponin T is indeed present in diseased skeletal muscle. In contrast, cardiac troponin I is exclusive to the myocardium. The commercial cardiac troponin T assay cannot distinguish between cardiac troponin T originating from heart muscle and cardiac troponin T originating from diseased skeletal muscle. The fourth universal definition of myocardial infarction guidelines were published in 2018. For the first time, these guidelines draw attention to the fact that cardiac troponin T is not cardiac specific. It can also be released into the circulation from diseased skeletal muscle. With this in mind, we're going to look at a very interesting paper published in Circulation in 2019 by Paul Welsh and colleagues. This study compares the high sensitivity cardiac troponin T with high sensitivity cardiac troponin I in the general population. Nearly 20,000 people were studied and followed up for a median of 7.8 years. The authors also performed genomic-wide association studies to see whether particular loci were associated with cardiac troponin I and cardiac troponin T in these patients. The main findings of the study were, number one, cardiac troponin I, but not cardiac troponin T, was associated with myocardial infarction and coronary heart disease. Number two, cardiac troponin T, but not cardiac troponin I, was associated with non-cardiovascular disease death. Number 3, the loci associating with cardiac troponin T and cardiac troponin I were different. So if we look further into this very interesting study, we note that cardiac troponin I was detectable by the Abbott's high sensitivity troponin I assay in 75% of patients, whilst the Roche high sensitivity troponin T assay only detected 53% of detected cardiac troponin T in 53% of patients. So it shows that these two assays are different in their sensitivity. The Abbott's assay is more sensitive than the Roche assay. Second thing we note is that the correlation between the concentrations of cardiac troponin T and cardiac troponin I was poor, with an R value of 0.4. We also need to remind ourselves that these were healthy people. The levels of cardiac troponin T and cardiac troponin I in these patients were very low indeed, well below the 99th centile cutoff used in clinical practice for the diagnosis of acute myocardial infarction. This figure here shows what we know already, that the higher the levels of either cardiac troponin I or cardiac troponin T, the greater is the risk for cardiovascular events. This is an interesting figure which shows that in 3 different categories of cardiac troponin T, irrespective of the category, it is the level of cardiac troponin I which determines the rate of cardiovascular events. I'm particularly interested in this group from my own study, where patients have high levels. By high levels, in my study, I mean patients who had a median concentration of cardiac troponin T of 80 nanograms per liter, with 25% above 140 nanograms per liter, much higher than the levels we're talking here. And yet these patients with chronic skeletal muscle diseases had a normal cardiac troponin I. So it fits in with what I see here. The level of cardiac troponin T may be high, but the risk is low unless the cardiac troponin I is high. As I said, in neuromuscular diseases, the level of cardiac troponin I is normal, and the risk of cardiovascular events is low. So let's scroll down further. So the authors say that it is most remarkable that we demonstrate the striking differences in cardiac troponin I and cardiac troponin T in terms of their association with composite cardiovascular disease and with specific cardiovascular disease outcomes. Then we have here the lack of association of cardiac troponin T with MI and coronary heart disease after adjusting for classical risk factors is unexpected, given the source of both troponins is cardiac injury. I'm not quite sure what is meant here, because as I've just said, cardiac troponin T has a dual source, myocardium and skeletal muscle, whereas cardiac troponin I has a single source, i.e. myocardium. The authors do recognize this when they say that cardiac troponin T is known to be transiently expressed in fetal skeletal muscle, and it may be possible that non-cardiac tissues express cardiac troponin T in some circumstances, for example, in patients with neuromuscular diseases. So all in all, a very good paper. The findings are in keeping with the contrasting biology of cardiac troponin T and cardiac troponin I. Cardiac troponin I is cardiac specific. Cardiac troponin T is not. It is expressed in regenerating skeletal muscle as well as the myocardium. Thank you very much.